Mr. Sánchez of Boston.
Gracias, señor portavoz, y a través de usted, a todos los miembros de aquí de la Cámara de Representantes. Lo que usted ha permitido aquí llegar a esta Cámara es algo bastante grande. Es algo que en los pasados 10 años nosotros hemos tomado cada día, mirando cómo el sistema va a atender a las necesidades del pueblo. Este pueblo grandioso que es tan diverso y tan grande, más de 6 millones de personas que tienen diferentes aspectos de cómo es que el sistema de salud le provee servicios. Folks,
Gentlemen,
all
I
right,
want to congratulate
so there's a
the
couple of
gentleman.
us.
I want to congratulate. You know, sometimes I feel like that when I'm talking to people. They don't, I get the same type of response.
And that's the point, Mr. Speaker. That's the point. The bill before us today tries to make sure that things don't get lost in translation when it comes to health care and the providing of health care to all of the citizens of the Commonwealth. Make no mistake about it. That's what this is. Because it's not only language, it's about where people come from. And it doesn't matter if you're black, brown, anything. It matters about where you come from and your own experiences and what the role of the Commonwealth and what the role of the administration has in making sure that state agencies are paying attention to those differences. Why? Because people suffer from different things differently when it comes to when they're in our healthcare system. We've been working on this issue on House 3969 in various forms for a number of years now. The gentleman from Boston, from the South End, and I, the gentlelady from Roxbury, the gentleman from Springfield, and I, for over 15 years have been working on this issue to try and make sure, again, that we look at how do we drill down the data, how do we drill down the experiences of people. There was a commission on to end ethnic and racial disparities that back in 2007 that made this one of the priorities. And that commission had a diverse group of stakeholders from providers and insurers and individuals and organizations that came together. And Mr. Speaker, today's a really big day. It's another big day in another chapter of our road to successful health reform. Because despite our efforts in health reform, minorities have a disproportionate burden of death and disease and disability. 75% of spending are on chronic diseases. And these are conditions that are preventable and disproportionately affect people of color. In particular, with African American and Latino citizens, they have a higher mortality rate and worse health outcomes. Asthma rates that are 4 times higher than non-African and Latino children. 19% of Latinos and 13% of African Americans reported not seeing a doctor due to cost, compared to 8% of other adults who reported the same issue of non-Latino and non-African American. Only 29% of Latinos with mental illness actually receive health care, mental health care, compared to 52% of non-African American and non-Latinos. Disparities are also apparent in clinical outcomes, but are rooted in broader social conditions. Only 20% of health status is determined by medical care. And the socioeconomic, behavioral, and economic environmental factors account for 80% of overall health status. In Massachusetts, incomes with less than $40,000 are twice as likely to have diabetes in families that have incomes of more than $75,000 annually. Diabetes hospitalizations or 4 times higher than the rate of Asian and non-African American and non-Latino citizens. And from 2005 to 2008, 17.3% of homicide deaths in Massachusetts were African American. 5.6% were Latino. Why do we need this? The benefits of a dedicated Office of Health Equity are clear. It's to improve the communication and the coordination and duplication across state agencies to make sure that we're utilizing our scarce dollars to make a better impact, and to make sure that we leverage the cross-sector training and experience that we do have, and also foster mutual understanding in all of the agency's roles and its perspectives to stakeholders, and also to serve as a single point of access for partners outside of state government. The complexity of the challenges that require the focused leadership of the Office of Health Equity is designed to provide coordination and ideas. We have to make sure that disparities don't continue to broaden. We have to make sure that in all of our health policies and health, that we look at our communities. Because by 2043, the majority of residents of the United States of America will be people of color, who at this time are disproportionately low income and living in disadvantaged communities. So we need here in Massachusetts, as we have always done, to stay ahead of the curve and to allow the residents of the Commonwealth, all residents of the Commonwealth, to enjoy access to high quality and cost-effective health care, not only for us here in the building, but those folks who count pennies to pay for their prescription drugs, as you mentioned today in your remarks, Speaker, to pay to keep the lights on, and in terms of health care, to reap the benefits of good health care outcomes. So thank you, Mr. Speaker, and thank you to all of you who have kept this issue alive for so long. And I urge you to all support this legislation. Y cuando tomemos un voto, que se tome el voto a través de los sís y los nos. Oh, I'm sorry. And that when a vote is taken, that the vote is taken by a call of the yeas and nays.
You said that in Spanish, actually, didn't you,
that was
earlier? Mr. Sanchez of Boston moves when a vote is taken, be taken by a call of the yeas and nays. All those joining with him will please rise.